How's it going, everyone? Welcome back to the channel. My name is Gianluca, aka Dr. Calcagno, and I'm a final year family medicine resident that just got off of my ICU block. We're finally done. I put the vlog up the other day, and today we're going to be doing a Dr. Glaucomflecken reaction to that video, looking at the intern's first day as a doctor in the ICU. Now, here's the thing with my ICU rotation. It beat me up pretty good. It was a month long for those of you that have never been on an ICU rotation before. The hours, so it's Monday to Friday. Shifts are about 10 or 12 hours long. Then your call shifts are 1 and 4. It's a 24-hour shift, and then every second weekend you're on a 24-hour call shift for that weekend as well. And a lot of people ask, you're on family medicine, why is it that you are doing an ICU rotation? And it's an elective. I chose to do it because I thought that it would be really, really important, especially someone that wants to do a little bit of rural medicine and wants to work in some rural hospitals. Gave me a lot of experience running codes and some really crazy kind of critical care medicine. But halfway through, like you're sleep deprived, you're feeling just not your best. And one of my friends actually sent me this Dr. Glaucomflecken video, and I watched it in my call room like super late at night. So shout out Dr. G. And I was just laughing to myself in a call room for like a solid 5 minutes. The video was like a minute long, but it really kind of made my night. So to anyone that hasn't seen it yet, we're gonna dive right into it.
Hi, I'm the new intern. It's my first day as a doctor. First day as a doctor. Hi, so I noticed this ICU has like 30 beds. How many of these patients am I taking care of tonight? All of them. You sure?
So right off the jump, I'll say that for myself, I did my ICU rotation, it was about month 15, 16, maybe even long, actually 17, 18 of my residency. And I can't even imagine starting off in an ICU rotation. I think that if you're going to do an ICU rotation, what you need to keep in mind is that everyone there, these are the sickest patients in the entire hospital. And to those of you that have family or loved ones in the ICU, like I said in my last video, I'm really, really sorry to hear that. But I want to talk about like the behind the scenes curtain as someone, a trainee that's not really familiar in that environment and what it's like going through for your first time. Because you really do want to help people as best as you can. But this is an environment that normal people don't really hang out in. And I don't care if you're an ICU nurse, you're an ICU pharmacist, you're an ICU doctor, you're doing things, you're in a place that many people are never going to be in. People are dying left, right, and center all around you. And it's up to you when you're there to keep your head on your shoulders, remember exactly what's going on with every single one of your patients, and then seeing new ones too as they come into the ER, and somehow hold it together even in front of the families when they come in. And it's not something that I think that I could have done my first day of residency. No way. Do medicine first, like your internal medicine rotation, do emergency medicine next, and then put those together and go try out ICU later on.
Potassium's low? Yeah, I'll put an order in, no big deal. I mean, you can't kill a patient with a little potassium, right? Oh, sure, I'll put the order in, yeah. How do I order that? I don't know how to order that. What's the dose on that? If you were putting that order in, how would you order it? I'll tell you what, I'll just sit right here and you guys just tell me exactly what to order for the rest of the night.
Okay, so now the scary part for both patients and trainees and residents. Every time you see a doctor do a really amazing procedure, whether that's bedside chest tube insertion, or you're doing a lumbar puncture, or you're doing a PICC line insertion, or anything really on ICU, you're managing multiple different medications, for example, there is always a first time that doctor has done that, especially when they're in training. So picture your very first time on ICU. What happens is you get there, maybe you get there at 7 o'clock in the morning and you're there for a 24-hour shift. So rounds will start, the handover at like 7:30, and then you'll do your 12-hour shift or your 10-hour shift until the night team comes on. That doctor gets to go home that you were on for the day, but you're still there because you're also the night team because you're the resident. And then depending on what staff doctor you're with, that'll determine how independent you need to be that night. Because there are some that are happy to teach you and show you all these different things. And there are some that would prefer that you don't call them for things that are not necessary, as managing electrolyte abnormalities in this case. And then it's your job as the resident to walk around the ICU floor and let all of the nursing staff and all of everyone there know that if anything happens, your first call as the resident. That means you're taking all of the different things that could possibly go wrong as first call, as a first night that you're there as a resident. And that's the scary part here. And that's the part where you really have to go back to what you learned in medical school about the different diagrams, about knowing what you don't know, and then not knowing what you don't know. And then the not knowing what you don't know is what keeps you up at night when you're on the ICU block, because you totally can kill someone by giving them too much potassium, and most people know that. But there are so many different electrolyte abnormalities, like even within potassium. You could have hypokalemia. If you have hypokalemia, then you're predisposed to QT prolongation and torsade de pointe. They could deteriorate into ventricular fibrillation. On the other hand, if you have hyperkalemia, that's too much potassium, then that could deteriorate to asystole and also VTAC and VFib. And you have to do things like shift the potassium in that case with insulin and calcium gluconate to stabilize the membrane and glucose. But it gets really, really complex. And that first night when you're there, that's the fear that you have to learn how to adapt to in your time on ICU, or that's what I saw anyways.
80 over 40? Page the doctor, yeah. Oh, wait, that's me. Another admission. Can I say no? No, okay. All right, thank you. Hey, everybody, I'll be in the call room. No, if I sleep, people will die.
So my first day on ICU, I walked in, and picture all the different rooms kind of side by side with a glass window so you could see the patients inside. And you could see their monitors. They turned their monitors towards the window so that you could keep track of their vitals. And in walking to receive handover on the very first day, I saw a gentleman reading a newspaper in his bed, and his blood pressure, no joke, was 56 over 32. And I've been in residency for about 18 months so far, and in all of that time, I had never seen a guy look so well with vitals that were in the tubes. And that's when I knew that ICU was just going to be a different animal altogether. And I was right. I was lucky enough to have some really amazing ICU doctor preceptors, the best of the best, as far as I'm concerned. And these are the type of people that in the middle of an emergency are, calm, glass ocean calm. You cannot shake them. And it's this type of training here that starts in residency. Many people ask me, why are we still doing these 24-hour rotations as a resident? And it's because the training, the amount of stress, if applied properly with the right type of supervision, produces those results to be the best of the best. The ICU doctors, they really are in their element there. And I'm thankful that there are people like them doing that, and I'm thankful that they were able to train me, and even just be with them for a month, came out such a better doctor on the other side. But that doesn't take away how rough it was for me personally. And I don't know, everyone might be a little bit different, but you guys saw in my vlog, I brought an alarm clock. I wouldn't let myself sleep for more than an hour at a time, because if you fell into a deep sleep and you got called on a code blue and you miss it, where's your excuse, right? And so it was not a fun rotation at all, but one that I would highly suggest to anyone that's even a little bit interested to try and get in there. And it's not going to be fun, especially the first half. It's not going to be fun. You're going to be a fish out of water. There's going to be patients with a fentanyl drip and 2 different types of vasopressor and all these other medications that you won't see anywhere else, and you'll have no idea the dosing and how to administer them properly, but do it anyways. And buy the nursing staff some coffee and get them to help you out, because they've been there forever. It's a real tip, by the way. Try your best to learn. And thank you once again to Dr. Glaucomflecken for this video, because it got rough for a little bit, and I came on the other side so much better. This video really made me laugh, and I hope that it made you guys laugh too. And to anyone in training, be the best doctor you can be. And to everyone else, best of luck with whatever you got going on, and we'll see you all in the next one. Exams coming up, board exams. We are nearing the end of residency, and I feel like I'm on hospitalist right now, and my job is so serious. There's so much happening all the time that to me, this has always been a fun outlook to make videos here on YouTube and have a few laughs sometimes, even at the medical training process. But yeah, see you all in the next one, and thanks for watching. Everyone take care.